Shan, now it's visible from my end, showing reflecting. I can see you on YouTube. See from if your end it's visible.
Someone typing TV set is open. Can't really hear anything.
Shan, now it's visible from my end, showing reflecting. I can see you on YouTube.
Yeah, I'll just check. Yeah, I can. Yes, I can see the poster.
Great.
I think it's working, Harshit.
Okay, thanks.
Harshit, please make Professor Bruno Markel also co-host. And Shen.
I'll be back in about half an hour. I have to do a presentation. Yeah, that's okay. But
Just now they started, right?
Okay, I think we're well in time to begin now. People can keep joining in as they come. We're beginning at 6:30 in the evening, and we expect this to go on till at least about 2.5 hours. So don't think we take more time to begin. Welcome everyone, and uh, as many of you would be aware, this is the 5th webinar in this series of webinars that we have organized as the Center of Social Medicine and Community Health to end the year of celebration of 50 years of the center. The overall theme is interdisciplinary public health in the 21st century, bridging the science and social science dimensions. This is a theme that emerged from our discussions last year with a large number of colleagues from across the country when we initiated the year of celebrations of the 50 years. And we realized that this was still a central theme, though to many of us it's the most common sense, given the vast range of subject matter of public health, the range of disciplines involved in dealing with those subjects, and the integral nature of the actions that have to be taken.
On this time.
And therefore, as we can I please request all those not speaking to please mute themselves? Thanks. Yeah, so we began with laying out the contemporary challenges with the first People's Health oration titled The Global Health Challenges of in the Era of Polycrisis and Responses by Researchers by Professor Franz Baum from Adelaide University. The first webinar that we started with was defining the contours of public health, taking this whole issue in its centrality because there is a whole range of ways in which people define public health, view its subject matter and its range of theoretical frameworks and so on. And therefore, we felt the need for defining what would an interdisciplinary public health mean. We went on from there to examining epidemiology and the social sciences. And the speakers in both these laid out very clearly the importance of linking the biological, the environmental, and the social all in an integral way. And for doing this, the challenges of being able to bring people from different disciplines moored in their own disciplinary moorings together into the interdisciplinary frame. The third webinar was on the politics of knowledge and integrative health systems, which brought in the additional issues of the ontology and epistemologies and diversity of epistemic views on human health and on healthcare. The fourth one, therefore, took on the challenge of how do you teach and bring in the understanding of different disciplines and have students who are able to cross disciplines and address the contemporary challenges, including inequalities in health and the hierarchies that lead to those inequalities. The social dimensions seen not only as social determinants of health, which have come into common parlance, but the pathways by which those social determinants lead to and influence health status of populations and its subgroups. This particular webinar is taking on from the pedagogy to research in terms of focus on health systems research and policy studies. We hope to learn about the plethora of approaches that are in this field today and that have seen various advances in the last 2 to 3 decades. One webinar will probably not cover all the paradigms and ranges of approaches that exist in the field today, but we certainly hope to learn about. Can you please mute yourself? And learn from the eminent scholars we have today as our main speakers and the discussants who will follow. With that, I would request Dr. Kotwal, Executive Director of the National Health Systems Resource Center, Ministry of Health and Family Welfare, Government of India, who is co-chairing this session, to take over and give his opening remarks.
Thank you, ma'am. Good evening, everyone. So the context has already been set by my co-chair, Dr. Ritupriya, ma'am. Just a quick, few of the points from my side. Like, as we all are aware, health systems research and policy studies are the drivers for health systems planning, decisions, and implementation. So Indian health systems have evolved with changing health needs, where reforms across the health system strengthening pillars have been demonstrated for improving the functioning and achieving the overall health outcomes. The field of health policy and system research, HPSR, it used to be called as health systems research. Now, health policy word has been specifically also added because it is eventually coming into the policy, helping the policy, driving the policy eventually. So this field of HPSR is currently experiencing an unprecedented level of interest. I'm currently in Jakarta attending a conference on primary health care organized by World Health Organization, CRO. And here too, every day of these last 3 days, we have been discussing in some or the other session about the health policy and system research and the implementation research associated with that. And the strength of HPSR is the health system strengthening approach and its potential to directly influence health policy through an evidence-based approach. And we know that for any effective policy planning and implementation, it is important that it's backed by relevant and specific evidence and learnings. And does any policy framework which lacks intensive practice derived through evidence and experiences from the field would not yield effective results. And at the policy level, NHSRC has been instituted to provide both research and technical support and as a work as a think tank to the Ministry of Health and Family Welfare across all the domains of health systems strengthening. Our role at NHSRC in generating evidence and supporting research and evaluation, including implementation research, has been clearly defined in the National Health Mission framework as well. So we as a technical arm of the Ministry of Health have not only been supporting the HPSR activities, but also synthesizing the evidence generation and translating the research into policy actions. Because we are involved in the policy formulation with the Ministry of Health. I'll just quickly mention few examples. The details are available on our website. One is an older study on ASHA evaluation, 2011-12, which led to policy level changes in the ASHA program guidelines. The JSY, which was part of the NRHM, it later metamorphosized and went into GSSY as such. And that JSY evaluation led to strengthening of the program for effective service delivery and clubbing Janni and Shishu Suraksha Yojana as such, GSSY. We recently also conducted, the Kilkari and Mobile Academy and Mother and Child Tracking Facilitation Center. We evaluated that. And based on that, all these three have been extensively revised. The revised version will be implemented shortly, and wherein we realized that they were effective, but not to the extent they were supposed to be, and the reach was also not was inadequate as such. NHSRC and Center of Social Medicine and Community Health JNU, both of us collaborated on the HPSR framework, and that what Dr. Tibri also alluded to. And this webinar, we are looking forward to further enrich our knowledge about HPSR and looking forward to enlightening talks and discussions. And to begin with, we have two keynote speakers of international repute who are very well known and respected for their expertise in their respective fields. and it gives me great pleasure to introduce both of them. Professor Bruno Marshall, he is a professor and head of the Complexity and Health Unit at the Institute of Tropical Medicine, Antwerp. And after graduating as a medical doctor and obtaining a degree in tropical medicine at the ITM, Professor Bruno worked for 6 years in Nyamira district of Kenya as a medical doctor and hospital director. He joined the Department of Public Health ITM in 2000 after obtaining a master's in public health. He carried out his doctoral research on the influence of health workforce management practices on performance of hospitals in Ghana and Tanzania using realist evaluation as the main methodology. In 2011, he successfully presented his PhD dissertation titled Why Do Some Hospitals Perform Better Than Others? A Realist Evaluation. Subsequently, he has also undertaken and supported large number of research projects with a realist or theory-driven component. And interestingly, we have been having discussions here about the research frameworks and all, and realist, this thing is the one of those on which we collated 20 odd studies that the WHO CRO team and NSRC was part of that, and 20 odd studies from the entire Southeast Asia region regarding the primary healthcare current approaches as such. Professor Bruno is currently working on urban health systems, health system adaptation to climate change and resilience, and research methodologies for complex issues in health and eco-health. I have great pleasure in inviting Dr. Professor Bruno Marshall for his talk on the subject. Over to you, Professor Bruno Marshall, please.
Thank you very much for your very kind words, and in fact for the invitation. It's really a pleasure, but also an honor actually to have this talk with you. So what I will do now is actually spend a bit of time on the journey that we at ITM, and specifically within the Department of Public Health, we kind of made in the last 25 years. And I'll use realist evaluation as a way to illustrate how it kind of gave us a way to deal with the complex nature of health and of health systems. And I'll also use it to see how the paradigms which are being used in health policy and health systems research actually can be discussed actually, and how realist evaluation kind of fits in. So I'll have a bit of a background here. I'm taking you back to the year 2000 almost, let's say 25 years ago, where you can see that the kind of projects we had, the topics we were looking at, were very much focusing on aspects of health service delivery, management, there are aspects of leadership as well there. We started kind of getting into policy formulation and policy implementation. And the kind of methods we used were very much old school at that stage, if you want. Some people were very much busy with action research. The case study design was being used, or what was called qualitative studies, basically based on interviews. Some kind of mixed methods research, if you want, and these were often made in collaboration with the epidemiologists who were working at our department. But we felt quite quickly at that stage that we needed new methods, actually, new methods to do research that would allow us to disentangle the complex nature of causal patterns in health and health systems and health services, but also to be able to better contextualize our research findings and to kind of decontextualize them. And I'll come back to that. But I want to show you a map first, because the Institute of Tropical Medicine, of course, has its roots in tropical medicine, as the name says so. It was instituted more than 100 years ago, basically to deal with health and healthcare in what was then the Belgian colonies of Congo, Rwanda, and Burundi. After the wave of independence in the 1960s, the scope of work at ITM dramatically increased. And in fact, over the years and still up to today, because here you see the map indicating our partners all over the world, we still work basically in the global south. We are getting into research in Europe increasingly so, but our original mandate was very much working in the south. And we were confronted with the challenge not only of understanding how health was being achieved in these countries, but also how context played a role into that. And we often had kind of a comparative perspective, but we lacked the tools to really make sense of that. So at the time, we had a number of papers coming out in different kind of journals, questioning the kind of traditional methods of research being done in the field of public health, one of them being randomized controlled trials. We had also, in parallel, in a different discipline, in clinical medicine, the emergence of the word complexity. So you saw around 2000, 2001, 4 papers being published in BMC, and they were introducing I think, for the first time, this notion of complexity in healthcare. It was quite an influential series. And again, that was followed up by other papers, other people more explicitly actually asking for new methodologies, for alternative ways to deal with the problems of health service management, of health service research, basically, pointing to complexity theory. And that was the time when, in fact, we kind of understood that a lot of the difficult challenges in health systems research or in health policy research are actually caused by the complex nature of not only interventions in public health, but also the way in which these interventions intervene in social systems. And where the interventions as such are not just interventions, but basically programs carried out by people. And so the human factor was quite important. Now, I'm not going to go deep into the kind of key characteristics of complex systems, the non-linearity, the fact that behaviors actually, of the outcomes rather, of what we see in complex systems emerge from the interaction between people and context, but also between systems and the larger systems in which they're being embedded. I think we all understand very clearly the fact that health, as health status, is a multi-determined outcome. And that's typical for, in fact, complex issues. So we very much had issues there. And one of the traditional questions was, how do we attribute outcomes of interventions to the actual intervention, knowing that there are feedback loops, that there are time delays, that there are multiple pathways, that a lot of what we see now may not be due to the intervention, but be the result of something that happened before. So we had kind of multiple methodological questions here. Now, at one point, one of our colleagues actually came upon this book, and it's called Realist, or still at that stage, Realistic Evaluation, written by two sociologists and criminologists, that's Ray Pawson and Nick Tilley. And the book actually made quite a shockwave at our department. And with a number of people, we started trying to understand actually what this thing was all about and how it would have kind of a use in our research practice. Now, that led, in fact, then at some point to some of conferences and things we organized. So again, a third stream, if you want, besides this kind of call for complexity-sensitive methodologies on one side, and our quest to better understand complexity, to find better methods, better tools to deal with it, kind of in parallel happened something else, and there was this movement to create this field which is called health policy and health systems research, which was in fact around 2010, based on a number of papers by a number of influential colleagues, and that led to the first conference, symposium on health policy and health systems research in Montreal. Now, later on, in fact, it was followed quite successfully by biannual conferences. The last one, or the next one, basically will be in November 2024 in Nagasaki. And so, what is this field of health policy and health systems research? I think it's good to understand it as kind of a reaction against something else. It's a reaction against the kind of traditional definition of public health, in which the traditional methods of epidemiology and statistics, or perhaps purely qualitative research, would be used to make sense of policies, policy formulation, policy implementation, but also systems aspects and health service organization. It was quite an ambitious definition in the sense that it would not just look at health systems or health policy as such, but as a field that would try to inform how people, societies, can actually organize themselves to reach these collective health goals. And you can read up on the justification of the field in this reader, the methodology reader, which is a very useful book, because not only does it explain a bit the roots of health policy and health systems research, but it also kind of explains the basic principles. And then it offers a wide range of papers illustrating specific aspects or methods used in health policy and health systems research. I think what was quite important for us was this acknowledgement of the fact that in health policy and health systems, we need to deal with complexity. And that's, you need to draw upon multiple disciplines to make sense of that complexity, that it's in fact requiring an interdisciplinary approach. This is the way the original authors of the reader actually positions the different paradigms that are used in health systems and health policy research. And they kind of put on the left-hand side positivism, okay, knowing, of course, that there are multiple evolutions of that kind of paradigm. On the left-hand side, positivism. On the right-hand side, relativism or social constructivism. And they positioned critical realism in the middle. And I think for us, that was quite an important thing, because it kind of put a spotlight on an alternative paradigm that was not yet known widely in our circles, at least in public health, and which would offer a very useful pathway into understanding these complex pathways. Basically, critical realism is aligned with scientific realism, which is the foundation, as we'll discuss in a few minutes, of a school which is called realist evaluation. So it gave us, in fact, kind of a visibility, a positioning of this school of realist evaluation, show that there are, in fact, alternatives to the traditional positivist on the left-hand side and relativism on the other side. Okay, now let's go a bit into kind of the key principles of realist evaluation. It's going to be a bit of a frustrating exercise because it's going to be condensed over 5 or 6 slides, and it's really not doing justice, of course, to the whole thing. But as a teaser, what I would like to do is kind of present you the basic principles. So any kind of paper that would pick up that is based on one of the approaches of realist evaluation will often mention this, what is called perhaps the realist mantra, which is the question is not so much does it work, if you want to ask kind of the research question, but rather what is actually working for whom? In what kind of conditions does your intervention work? How does it exactly work? Over which kind of duration and why? And so the whole idea of realist evaluation was to say we need to give policymakers and service managers and anybody actually wishing to understand how things work with much more information than just evidence on the effectiveness question. And that kind of information would be useful for policymakers and program managers because research in one setting would be decontextualized, would be kind of pulled out of its context, still taking into account context, and we'll see how we will do that, but would offer useful information for other policymakers in other settings because it would offer them kind of answers to the question, well, it works in that context, and if you do it perhaps in a slightly different way, it may also work in your context. So that's a bit the kind of quick introduction to the why of realist evaluation. Now, I need to say here that initially the book was titled Realistic Evaluation. Realistic, the ick was dropped quite quickly, and now we use it as kind of shorthand for both evaluation approaches based on realist evaluation principles, as well as research and knowledge synthesis. So there are kind of 3 main streams, if you want, within what I will call realist evaluation. It is not only evaluation, there's a lot of primary research included as well as secondary knowledge synthesis. So it's part of a school that belongs, that I can actually call theory-driven schools of evaluation and research. More known probably is the theories of change approach, which is a very pragmatic way of trying to have participation in evaluations, American-based. There was also at the same time more or less the emergence of theory-driven evaluation, again, an American approach to evaluation. And so realist evaluation shares kind of common principle that we are not so much interested by the method, but we are interested by the theory. And the theory is to be understood as a hypothesis or set of assumptions, an explanation of why things happen. And so it's very much driven by the nature of the problem and a potential explanation of the problem, and not so much by the actual methodology. And so it was a push against very much quantitative schools of evaluation for which everything could be addressed in a quantitative way, or the more kind of qualitatively based evaluation methods that were primarily driven by the method of qualitative research. So it speaks to a lot of people, at least in the kind of traditional public health schools, if you want, because of the fact that it starts with a hypothesis. And the idea is very much that you try to build upon existing knowledge to formulate that hypothesis. The hypothesis not being just a question or an answer to the question, does it work? But rather, we expect that this intervention carried out in this way will work for these people because of that and that reason, and if only if in the context we have a number of context factors that are present. So it starts with that hypothesis, and by doing research, you try to kind of refine the hypothesis, and gradually, slowly, you accumulate knowledge that will lead to a more refined theory. Okay, I'll come back to that in a second. Because at the end, what you want to do is to reach this level of middle range theories where you kind of accumulate your insights to such a degree that what you found in one setting now has enough body by testing it in different settings to probably explain similar situations, similar outcomes in other settings. Okay, so what is different then between the other schools of theory-driven research? That is basically the philosophical roots, both theory-driven evaluation and the theories of change approach are very much pragmatic. They don't have this kind of deep kind of philosophical foundation in the paradigms of science. So I'll not go deep into that right now, but in fact, I'll discuss that step by step in the next slides. There's a specific ontology, there's a specific epistemological position. There are ideas about causation and about methods that are specific to realist evaluation and which are different from the other schools. Okay, so let's start with this brief list. And again, I'm doing not really justice to the field. My idea here is to briefly introduce you the kind of key principles so that it may make sense perhaps to you if you come from other paradigmatic backgrounds. The first is the realist ontological position, which is realist in nature, which is rather empirical or empiricist in nature if you want. It leans much more to the positivist side, whereby realists would say, well, there is this reality that is existing independently of the observer. It's independent of our knowledge about it. I know my house in Mortsel, not far away from here. It is there, even if I'm not here, even if I'm actually not seeing it. So independent of my observation, that house is there. And so what realist evaluation kind of adds to the purely positivist ontological position is to say that it's not only what you can observe that is real, it's also a lot of intangible things that are at first hand not visible, that are important because they have a real effect. And so there's a lot of attention in realist evaluation for the social world, for social mechanisms of change. The second is the epistemological position. Here, realists will lean more to the constructivist or the relativist position. And it will kind of acknowledge that, yeah, the knowledge we can create about reality is very much depending on the researcher's position. It is constrained by our human capacity to deal with our visual, auditive, and other inputs. It is also socially constructed. And it's quite a humble approach. Our possibilities to kind of understand reality are limited, and therefore the findings of our research are very likely to be incomplete unless you manage to get that kind of degree of accumulation I talked about. But different from the purely hardcore relativist position, it is possible in a realist perspective to understand gradually in a better way, in fact, reality by making your theories more rigid, more rigorous, more, not rigid, but better, basically. So it's by building and developing theories and testing them that you can gradually develop a better knowledge of reality. Now, an important part here, and that's kind of already speaking to our request at ITM is realist evaluation actually allowing us to make sense of complex systems? Yes, it is, because it very much acknowledges that any kind of intervention, any kind of actor is embedded in a larger system. So it's a very much open perspective on systems and on complex systems that is adopted by realist evaluation. Now, more central perhaps to the approach is the notion of generative causality, whereby it is said that in contrast to the more positivist school of thinking, whereby it is sufficient to demonstrate causality if you demonstrate what is called constant conjunction. So the situation whereby specific outcomes are always preceded by specific inputs. No, what is said here in realist evaluation that you need to open a black box between anything that you do, an intervention or an existing situation, and the outcome of your intervention or the evolution of the situation. You need to open that black box, and you do that by looking at mechanisms. And mechanisms are processes, psychological processes, social processes that explain how people take action in response to a particular situation or an intervention, do things, and therefore change the actual situation, or perhaps do not change it. And we have a specific tool for that, which is called the context mechanism outcome configuration, as a way to try to find these kind of patterns that you may observe in terms of causes. Now, how do we need to understand this interaction between a mechanism, context, and outcomes? The idea is that actors have this potential to change things, and they react to the inputs of the intervention. They deal with that, they look at opportunities, and I'll give you an example later, and then they decide whether they will follow and adopt that intervention or not. But actors are always, of course, part of a larger social system, a larger ecological system, and there is this kind of constant interaction between actors and structure, or between agency and structure. Okay. Now, let me give you a quick example. It's a relatively simplistic one. I don't think pay for performance is being used a lot in India at this stage, but it's a very popular kind of way to try to improve performance of health systems, health services in Africa, in some in countries like Cambodia as well. So what's basically the idea? You introduce in your health services system whereby any remuneration of health providers is tied to the performance, either individual performance or the performance of a particular health center. And that is supposed to lead to an increase in performance. And why is that so? Because money is considered to be a very strong motivator. And the underlying hypothesis here is that if you pay people in function of what they do, the way they will work harder actually is what you want to achieve, and you will achieve that goal if you pay them in accordance to their volume of work or the quality of their service. So increasing, in fact, revenue of people in function of their performance is a very strong motivator. So that's what we'll call the kind of financial incentive, building upon intrinsic motivation and that mechanism. Okay. Now, mechanisms, as I already said, is kind of traditionally defined by Posner and Tilly, so the godfathers of this approach, as the way people reason in function of the intervention they are encountering, and they look at how the intervention provides them with resources, with means, with inputs, which means that as a researcher, then you need to understand kind of the logic of actors. You need to understand how they think about the intervention, how they perceive the problem, and whether or not that actually led to a change in behavior. Okay. Now, automatically, this kind of opens the box in the sense of, I mean, the range of things that you may find when you do evaluations, which is very much common sense, of course, but not so much in the traditional way of doing evaluation. Perhaps that any kind of program that you institute will, of course, work differently for different people. You cannot assume it works in the same way for all people involved in your intervention. Now, in terms of the example here, the actors we are talking about here are health workers. They could be nurses, doctors, could be managers. And the idea is that we try to understand why this particular intervention would work for the different kinds of actors by reasoning about, well, what kind of people do we deal with? I think in this stage, you could say, if you have competent health workers who have very strong extrinsic motivation, but who are not paid very well, for these people, the intrinsic motivation might be weak, but the extrinsic one actually may work. So if you give them actually an extrinsic motivator and financial incentive, they're likely to respond to that in a positive way. But not all actors, of course, in health have that very strong extrinsic motivation. A lot of people are driven by intrinsic factors. And we know that if you impose very strong extrinsic motivating factors on intrinsically motivated people, they may be crowding out of that motivation. So there's in fact this need to distinguish between actors and try to understand how they may react differently to one particular intervention in function of their nature. What is important to understand in a realist perspective is that these mechanisms of motivation are not working in isolation. They only will work if the context conditions are right. So the notion a bit here is to say any kind of intervention in a particular setting will work if the facilitating factors in the environment are present, or if there are not too many constraints in that environment, which again is very much common sense. It's really systems thinking. The example that is given by Jill Westhoff, one of the main authors in this field, is if you drop a tennis ball on a tennis court, it will drop because of gravity. But if you release a tennis ball underwater in a swimming pool, it will not drop to the bottom. It will actually go up because in water, there are different kinds of mechanisms acting upon the tennis ball. It's this buoyancy that will push it up. And on the moon, it will also drop, but it will drop with a far slower speed because of the gravity, which is different on the moon. So context is going to be important because it will have an effect upon how people think about things, and it needs to be kind of right for your intervention to work. Okay, so in terms of, again, the pay for performance scheme, an extrinsic motivating factor will work only in specific working conditions. If I at ITM am asked to work on Saturdays and you give me 100 euro, in the context of the current salaries at ITM, 100 euro is not a strongly motivating factor for me to give up a weekday or a weekend day. If you would kind of double my salary, perhaps I may consider that. So it all depends a bit on actors located in a specific context and the way that context influences the way I think about the intervention. Okay, last point here almost, context matters a lot, as I already said. not only because it will shape the conditions for the mechanisms to be triggered, but of course, any kind of context plays upon implementation. It may also explain what you see as an outcome, as a kind of a confounding factor, if you want, if you would call it that way. So, to end this part on the principles, what's kind of the logic of release evaluation cycle? We identified the research question that leads to kind of developing the program theory, so this initial hypothesis. Study designs are defined. It's very much study design neutral. We often use combinations of mixed methods, so qualitative and quantitative methods. Also, to do the data collection, we need quite often to demonstrate quantitatively, basically, the effects. So we usually mix of both quantitative and qualitative data. It leads to a particular way of analyzing things, to a synthesis. We will have refined theory, which then goes through the next cycle in a different setting, or perhaps in the same setting at a different moment of time. And by running through this cycle a number of times, at the end, at some point, we will get to the point where we can actually recommend things because the program theory is mature enough now to inform policy. That's the ideal world. In actual fact, this cycle, of course, is often interrupted or stopped if the funding of the program runs out. Okay. So these were kind of the basic principles of release evaluation. You can see that it kind of spoke to us because we felt very much that it offered so much more than the kind of purely quantitative or purely qualitative approaches. It allowed us to open the black box between an intervention and outcomes. It had very specific kind of foundations in philosophy of science. It had a specific methodology to deal with that. And what we see is that it is being picked up in health policy and health systems research, in fact, since the 2010, around that time. Release evaluation and all of its kind of evolution, synthesis and research are quite big in the United Kingdom, where it was picked up very early on by the big funders of research. Also in Australia, Europe mainland, funding for release evaluation is still not easy to find. It's not that much known yet, but we see that it is being used increasingly so in a lot of research in the South on a number of aspects of health service organization, management of local health systems. You can see here kind of dimensions and examples, and they're listed also in the references at the end of this presentation. But it's also being used increasingly so in India, and here are a number of papers from researchers at the Institute of Public Health in Bengaluru, and it led to a number of courses being instituted by IPH as well. And I think in India, there's of course huge potential. There's a huge research field there. There's so much interesting things that are happening. And I think that, and that's why probably, of course, this seminar series is set up. Release evaluation may offer one alternative to the more traditional ways of doing research in the field of public health, specifically in the field of health policy and health systems research. So to conclude, because of its emphasis on knowledge and existing knowledge in the form of hypotheses or initial program theories, and the way it allows us to theorize, to strengthen our theoretical foundations, and therefore to build a better understanding of the social realities of the situation in which we work, I think release evaluation has a lot to offer to the field. It allows us to go into these complex causal configurations. It is definitely demanding a multidisciplinary approach, and that's also one of the challenges, of course. You will have to have people with different backgrounds in your teams, and it allows to bridge between different settings because of the theories it kind of constructs, which are always including that element of context and through the accumulation over time, actually enriching the insights into context. I'll stop here, and I would be happy, of course, to take your questions anytime. Thank you very much.
Thank you, Professor Bruno, for that enlightening talk. I would just like to add, when you mentioned the challenges, I think that, in theory, realistic evaluation can be carried out in several different circumstances and alongside other types of evaluation. But in practice, the skills and knowledge required to undertake this realistic evaluation, I think, are much, much greater than the other kinds of evaluation. So thank you very much for that talk about the complete details about the realistic evaluation. And while doing this, I'll just add that the evaluators need to engage with and buy into the underlying philosophy behind this realistic evaluation. So it's not that simple as you have tried to make it very simple. You have tried to deconstruct it, and that's what you have managed to do. But just a word of caution for all the others who are tuned in and maybe also listen to it or watch this video later, that you need to first understand the entire theory behind this, become an expert or work with experts in initial stages, and then only you could be take it. There has to be a convincing case for carrying out and which is justified by the larger investment. So I think I'll stop here for my comment with my comment. So with this, I have great pleasure to introduce the our second keynote speaker, Professor Indrani Gupta, who's currently the professor and head Health Policy Research Unit at the Institute of Economic Growth, Delhi. And this HPRU was set up by her only in 1998. It's a first of its kind in India. It remains among the few places in the country that conducts policy-oriented research on the health sector using tools of economic analysis. She has a PhD in economics from the University of Maryland, College Park, USA, and a master's in economics from the University of Delhi. Professor Gupta's work experience includes teaching and positions at academic institutes, the World Bank, and the Government of India. Her areas of interest covers a wide range of topics in the area of health economics and policy, including demand for health and healthcare, health insurance and financing, poverty and health, costing and cost effectiveness, economics of diseases, and internal agreements. Professor Gupta is a member of several committees of the Government of India and have been helping and guiding NHSRC2 since several years. And looking forward to your enlightening talk, Professor Gupta. Please, over to you.
Thank you, Professor Atul. It's really a pleasure to be here today. I'll just share my screen. Can you see my screen?
Yes, ma'am. Kindly make it slideshow mode,
yeah,
please.
I'll do that. Fine. So
Yes.
I must admit that when Ritu asked me to give this talk, I was wondering what exactly to say because I am a health economist, like it or not, and I have things to say both in favor and against some of the work that economists have done over the years in the health sector, on the health sector. So today, I'm assuming that there will be a lot of students in this group as well listening to us. I want to just walk everybody through some of the seminal landmarks in health economics that have informed policymaking in the health sector, and pointing out every now and then what else could have been done, but also leaving it to the viewers to understand the departures from some of the assumptions that economists make. So let me just start by a very simple definition of what do we understand as in health economics, and this is only to set the stage. Basically, as we all know that economists study the use of scarce resources, so we do that also in health economics. Health economists also look at how scarce resources are allocated to and within the health economy, and whether there are appropriate incentives in the system for those supplying and demanding health services to use those scarce resources economically. And because we fundamentally believe that resources are scarce as they are, priority setting is important. And the important thing is who sets the priorities. So economic analysis is in the health sector helps in that priority setting exercise. So as somebody has said, the health economics is the application of economic theory, which I'm not getting into because I know I'm not talking to economists here, but I'll point out some of the major theoretical underpinnings of what we have done over the years. Apply economic theory models and empirical techniques to the analysis of decision-making by individuals, healthcare providers, and governments regarding health and healthcare. That's what health economics economists do. Now, the fundamental premise or the beginning of all this was what we teach in Econ 101, which is the new classical welfare economics framework. And we assume that individuals are rational and they maximize their utilities, and they are the best judges of their own welfare, and the goodness of any situation, that is resource allocation, is to be judged solely on the basis of the utility levels of individuals, and all non-utility aspects we don't consider. And the metric is monetary, so willingness to pay is a monetary metric. and you separate efficiency and equity with a much larger focus on efficiency. So this is the fundamental approach that economists have taken in the beginning when it all started with the health economics. So the question was, does the market actually produce an equitable and efficient allocation of scarce healthcare resources? Now, the reason why I'm putting it there is that after this particular, and I'm going to say why markets do not, there was an avalanche of theory and also practice in health economics that was very, very rich in its breadth and depth. Now, the genesis started with Kenneth Arrow, of course, that it was observed that people often make decisions, and my previous speaker has actually alluded to much of this. People make decisions in healthcare that are not in their best interest. And the seminal work of Kenneth Arrow, Uncertainty and the Welfare Economics of Medical Care, he talked about uncertainty in the incidence of disease and in the efficacy of treatment. Also, lack of information, asymmetric information, and all of this can lead to market failure. Now, the question is that, of course, health sector has a lot of uncertainty, both from producers, provider side, as well as consumers, and there is a lot of information gap. So all of this lead to market failure in a competitive setting. So markets fail to provide equitable and efficient outcomes. And therefore, he argued that non-market institutions emerge that compensate for these market failures. Now, this particular paper of his had a profound impact on how healthcare analysis was being done, healthcare analysis, where it went in the subsequent years. Now, just to spend a little more time on this, because this is very important to understand what happened subsequently. So, of course, we now all know that healthcare is different and it generates market failure. And why does it do that? There are all these things that students learn in their first year of health economics, which is that it is a derived demand. You don't demand health like you demand apples or TV. You demand it because you want good health, but you also consume it at the same time. There are externalities. There's a public goods nature of health goods and services, huge informational asymmetries among providers, among patients, between providers and patients. And there's, of course, huge amount of uncertainty with respect to both the need for and effectiveness of healthcare. And as in any market where there are risks and uncertainty, insurance markets develop. And it has also been shown that insurance markets also have market failure. You can theoretically derive that and show that insurance markets also are subject to market failure. Therefore, due to this imperfect information and this relationship, you have this principal-agent relationships develop. Patients appoint the health providers to advise them in making decisions, and this is also a potential for supplier-induced demand, market failure in insurance market, and all of that. And therefore, we decide that it was quite clear by then that healthcare was different and did not adhere to the typical utility maximization theories that economists were fond of. Now, this whole the premise that individuals make rational choices was actually being questioned, and a huge body of work and research subsequently happened after Arrow's seminal work that talked about how individuals decide whether individuals could be patients, they could be providers, what makes them make rational choices. Now, a whole new area developed called behavioral economics, based basically from psychology. And the new assumption and the new belief was that people do not act rationally in the economic sense, even when faced with very rational choices. Given choices, they don't really behave rationally. So economists started to apply tools of psychology, essentially, which is now, this whole area is called behavioral economics. It has tried to apply it to health sector analysis. And the departure was that you flag deviations from neoclassical model outcomes, and you say that there are cognitive biases, and therefore all kinds of theories developed. The most famous one, big prospect theory, that individuals violate rules of rationality. Kahneman and Tversky, you've heard of them. Heuristics and biases, people actually take decisions based on rule of thumb. They have bounded rationality, they have limited attention capacity, limited knowledge and ability to forecast the future, so they therefore resort to rules of thumb. So therefore,
bullshit going to...
Is there a question? Okay, I think somebody's mic was on. So basically, behavioral economics was then informing health sector analysis in a big way, also in other areas, but also in the health sector. Now, health sector interventions, therefore, became a very important thing, because if markets fail because of uncertainty and risks, there has to be, and there are these behavioral issues, then who would intervene? How do you get better outcomes? New classical economics builds on market failure to justify government interventions in the health sector. So the point is that instead of the market, the priorities need to be set by the government by explicit rationing. For the development agenda, therefore, government interventions became a key area of research and focus. And given the resource constraints, it was very important to know what works. So the sequence is very clear. You have neoclassical theory, utility maximization, then you realize that markets fail in the health sector. Then you have all these behavioral economists telling you that people don't make rational choices. There is another reason to intervene. So for all of these reasons, we needed to know how governments should intervene and what would work. Now, because every choice has an opportunity cost attached to it, as economists think, the value of foregone benefit which could be obtained from a resource in its next best alternative views, you needed to economize on resources. And we also had enough evidence by then that in many low and middle income countries, government interventions actually do not work or work very imperfectly, leading to a massive body of work on evaluation, which my previous speaker also talked about. Now, there are two kinds of evaluation that I would like to right now focus on, and I'll only focus in this particular talk because we have limited time on the first one more, but I will refer to the second as well. So one was the impact of an intervention. How do you intervene? Where would it work? Would it work in one setting and not in the other? That's one area of inquiry. And the other was economic evaluation, where you compare alternative interventions with respect to their costs and consequences, and cost effectiveness analysis, cost utility analysis, all of that is part of that particular bunch. Now, the basic point is to know what works and when. So we are basically now talking about if the government has to intervene, it has to know what works, and it has to also economize on resources because resources are scarce. So economists decided that we needed to understand the relationship of the health sector with other sectors and actors. Now, this is a diagram that I often show because it goes, Mead was also my boss in the bank. But so this book is very interesting. It was written in 1991, where he talks about economics for health sector analysis with a very simple schematic first that, look, there are these health and population module, the impact on production, impacts on expenditure, impacts on welfare, and that directly impacts on health and population directly impact on welfare. So there are these arrows. But if you explode this diagram and have the arrows going in different ways, so you have mortality, fertility, population, morbidity, etc. You have income, and people work, and they have quality of work, so labor quality. And then you have all of these taxes, disposable income, all of that. And then on the right, you have what are the outcomes, your healthy days of life per capita, literacy rate, etc. Now, the issue was that he was just trying to show that it is a very complex thing going on in the economy. Now, the thing was that if all these links that I just showed could be measured and explained accurately, the job is simple for policymakers, right? But it cannot be done. So health economists studied each of these links separately at both the macro and the micro level. So for example, to generate evidence, they looked at health expenditure and health status, links between poverty and health, determinants of treatment-seeking behavior, demand and supply of medical care, links between health and labor outcomes, and use of statistics and econometrics, of course, then and now, very much part of our, the way we used to, the tools that economists used, health economists. Now, as I said, since resources were scarce, there was a need to know how best to spend these resources. And therefore, we needed to know what works, how, where, and who benefits. We also needed to know the causal effect of policies that aim to improve health outcomes. And there was a huge, discussion and debate among economists about how to get the right evidence on what works. Now, in the beginning, after health economics was triggered, this whole area by Arrow and then subsequently other people, observational or non-experimental studies were used. So they used simple econometric techniques, regression, instrumental variables, difference in difference, all of that. And the dependence was on survey data, all kinds of survey data, cross-sectional, time series, panel, etc. Now, I want to make one point here because, since we are talking about approaches and paradigms, now for a very long time, observational or non-experimental studies were being done by health economists all over the world, beginning with the West, but it also came to many of the other countries in the developing parts as well. Now, here, the dependence on survey data was very, very important. As we know, the survey data is basically a systematic process of gathering information or responses from a selected sample. Now, economists, empirical economists, and health economists use survey data extensively. But, when I say that all of you, especially the students of public health, should have questions that you must ask. Now, anybody doing survey should have these questions very clear. What are the research questions? What are we trying to measure? Does it require primary survey or do we already have evidence? What is the additionality, value added? How do you identify indicators to measure outcomes of concepts and for whom? That's also very important. Sampling and sampling techniques, somehow economists haven't focused too much on that, but that's a critical part of survey design and how we answer questions, because a lot can go wrong if the sampling is all going haywire. Of course, there's collection of data analysis, etc., and household service provider, a rich source of data on economic behavior and its links to policy. Now, there are various ways of collecting data. I mean, of course, case studies, primary survey, etc. Now, I want to flag the LSMS here because they did add substantially to the knowledge bank of development economics, but also health. Now, the LSMS, as they are called, Living Standards Measurement Study, is the World Bank's flagship household survey program. It focuses on strengthening household service systems in countries that they help. And the whole idea is to produce better data for evidence. And it has evolved continuously and is now, it contributes methodologically as well as analytically to answer questions on development. And the kind of papers that came out, for instance, on health from the LSMS, remember I said these are the links that they are measuring. So right now, it's not an equilibrium model that we're looking at. We're looking at particular links between 2 or 3 variables. So for instance, children's health and achievement in school, unconditional demand for healthcare in Cote d'Ivoire, dynamics of wasting and underweight in Ethiopian children, financing, chronic illness and retirement in Jamaica, willingness to pay for medical care, quality and cost in healthcare choice in developing countries. Now, to me, because I was actually also there when LSMS was, just exploding and a lot of papers were coming out. I think that the body of work contributed by the LSMS surveys and the papers were very, very important. They allowed us subsequently to move on and look at other ways of to be built on the LSMS kind of approach. So a good overview of what one can do with survey data. I would encourage especially students to look at Angus Deaton's revised book on the analysis of household surveys. But the preface is very important because he gives a critique of the current approaches that some of the economists have taken to do evaluation. So this is a very important book. I think it should be read by, some chapters can be read by all. So one problem that happened with these bilateral or three-way causation that was happening, I thought I would just flag it through this paper. So you were looking at socioeconomic inequality and is one of the most studied phenomena in health. And we knew that SES and health are positively related. But the causal pathways were still not very clear. So is health impacting SES or is SES impacting health? So most studies indicated that investment in education and human capital leads to better health outcomes, but there may be reverse causality. So it's possible that causal paths run from health to SES, and lower health status can restrict education, leading to lower income subsequently. Now, economists started getting preoccupied with the causality point that we are maybe missing some key results because we are doing our regressions or our analysis in a particular fashion. Also, unobserved characteristics at various levels may influence both education and health, so we need to also focus on those unobserved characteristics. Now, with this came another wave of new of an approach that had to do with experiments. So there were two kinds mainly. So there was this natural experiments, which is really an observational study, where the assignment of treatments to subjects has been haphazard, chosen by nature or policy rather than experimenters. So you have a natural experiment. Somebody, a country gets divided, or a kind of policy gets implemented. Something like that happens where you as an analyst you're not playing any role. So they are very useful when there has been a clearly defined and large change in the treatment or exposure to a clearly defined subpopulation, so that changes in responses can be plausibly attributed to the change in treatments or exposure. And similar econometric methods were being used to detect causality. Now, this is a list of a kind of work that was done with natural experiments. I just want you to look at the second column, where the second and third would tell you that you're basically looking at, say, legal restriction on pesticide before and after, restrictions on alcohol tax reduction before and after, some legislation before and after. You didn't do it, but it has been done in the particular country. So you could actually do a natural experiment and use all your econometric tools that to answer some of the questions. Now, the problem with natural experiments, of course, is that you can't wait for natural experiments to occur. It's one, it's a rare thing. It may happen, it may not happen. So in that situation, experimental approach where you actually do an experiment was initiated. So the aim was to trace cause and effect as before between defined variables or causality. So causality, everybody is very preoccupied with causality amongst health economists right now. So experimental research is research utilizing randomized assignment of participants to condition and systematic manipulation of variables with the objective of drawing a causal inference. So it's generally conducted within a laboratory or other control environment. So again, it's basically taken from psychology, the discipline of psychology. Now, with such experiments, you have internal validity. So your subject, whatever you're studying, has a lot of internal validity, but obviously you can't put it in another context. So external validity really decreases. Now, some of the major names in this obviously is Abhijit Banerjee, Esther Duflo, as all of you know, and he says in an RCT, the assignment of different units to different treatment groups is chosen randomly. This ensures that no unobservable characteristics is reflected in the assignment, and therefore we can attribute the entire change to the impact of the treatment. And one example that I'm going to give you about for this is what they did some study on long-term effects of targeting the ultra poor, TUPs, the ultra poor. And since they said evidence of long-term impacts of programs targeting the ultra poor are very scarce, they did this experiment by tracking the ultra poor 4, 7, and 10 years. You can imagine how much time and money it must have taken to do this in West Bengal, India. And both treatment and control households over time, they kind of followed, and to see whether they escaped the poverty trap. And they did find that the TUP, the ultra poor did benefit from the big push intervention, and it had a positive impact. So the results are not, I'm not going to dwell too much on that. But the point is that there are these people, a group of economists, and a big group at that, who actually think that such control experiments can answer questions of causality, and therefore make your public health programs or your interventions more effective. Now, as I said, so what are the challenges of this approach? Because this is now, it's quite common. Of course, a lot of critical reviews are also coming in. As I said, natural experiments as well as RCTs lack external validity and cannot be transferred to other settings. Deaton, in his book that I just showed you in the preface, now has said that they yield new insights and unexpected findings, yet they also have more problems than we anticipated, both in theory and practice. So it's the whole point is how the field has evolved. So initially, when it hit the world, it was the most important thing to do. But slowly, people are realizing the limitations of RCTs. Now, and he also says that statistical inference with RCTs is much more difficult than it at first appears. Causality can rarely be firmly established. The influence of omitted variables is not magically erased by randomization, and the lack of blinding can undermine estimation in the same way that failure of exclusion restrictions undermines instrumental variable estimation, which used to be a very common tool, instrumental variable. And they're also not, and this is what I'm saying, is that experiments are not always feasible or inexpensive. I remember when I was doing my PhD, my advisor used to say that before you do anything, you can look at the data and do scatter plots, crosstabs, summary statistics, mean, median, mode, over time, and you can learn a lot about your data. So Deaton actually backs that up. He is a very, very refined economist with a lot of very theoretical and technical expertise. But now he has also endorsed the fact that students need to actually look at the data over time and across populations very well to understand, and they will understand a lot more about what's going on before they jump into very fancy econometric techniques. Now, I just wanted to talk about, so the reason why I laid this down, and I didn't talk much about economic evaluation because that would take another half an hour. There are lots of critiques of economic evaluation as well. Now, since this is a public health group, I just wanted to say how to marry economics with public health. Now, there are enough economists who have now realized that the standard approach that mainstream and also others, behavioral and other economists are taking, still does not actually take account of the very nature of public health. So, for instance, Gavin Mooney has said that you need to recognize the social nature of prevention and public health. And until you do that, mainstream economics cannot throw much light on what's going on. Now, if evaluations are key in resource-constrained settings, there needs to be many more, have to have many more evaluations of public health interventions. Now, the interventions that are evaluated are not public health interventions. They are not population-wide. They are in subsamples of population or in specific regions and specific places. But for public health intervention, I think we still lack a consistent and an approach that everybody agrees on. Health economics is mostly focused on efficiency, effectiveness, valuation, how you value a life, and there are lots of critics of that as well, and behavior related to health and healthcare of specific narrowly defined interventions. And one has used cost effectiveness analysis and HTA, for instance. But valuation of life, how you value life, what all do you need to consider when you value a life, equity considerations, horizontal and vertical, non-health sector consequences. These are some of the key differences between clinical, medical, and public health. I forgot to write that. And public health interventions, even including when you look at cash transfers, conditional cash transfers, and you look at whether they worked or not. They only are for subpopulations, but if you actually undertake a population-wide intervention, you need to focus on all these much more than you have done so far. So public health interventions do occur in a much wider socioeconomic context, which is not as easily defined or generalizable, and can actually, the intervention can change shape during implementation. So how do you actually, and you can't pre-test an intervention, a public health intervention like that. It's just not possible. So in that context, how can economists actually help? The other part is that we need to focus much more on the social and cultural aspects to understand behavior and disease occurrence. And we know that public health interventions are multifaceted and context specific. So your multidisciplinary approach would really help. And in lower middle income countries, the socioeconomic dynamics are much more complex than in developed countries. And so are institutions, etc. So, and some other points are that so far economists have still looked at deviations from the market as their main benchmarking. Now, there are many economists who look at political economy because you really need to understand institutions. So more political economy analysis of policies required. How do you formulate? How do you implement? What are the governance challenges? Who decides which interventions to prioritize? So there has been not much work on government provision. Not many economists. I mean, even as a public, when public choice is offered as a subject in a master's program, not many people take that up because we know that governments also fail. So how do you actually try and understand that? And Fox has actually said this, that institutions matter. The peculiar institutional features of healthcare delivery, if taken as a serious social response to genuine organizational problems rather than a series of accidents, force one back to a questioning of the usefulness of many of the standard tools and concepts of economic analysis and rethinking of their underlying methodology. So institutional economics is also there. Some people actually do that, but they are not, these areas are not marrying, they're not coming together. Finally, efficiency is still given much more importance than equity. There's a separate point. I always think that we really do not really care enough about the deprived and the poor. We don't care enough to do things that may be simpler, but more targeted. There is an important thing that is overlooked, which is funding sources, impact research agenda, and priorities. So whether or not you're adopting a vaccination or a vaccine, going from something tetra to penta or whatever, you have to look at who's funding your research. So that should also be taken into account. And in our settings, in less developing countries like India, impact of private sector on resource allocation is something that is very, very important and not taken enough note of. Now, I'll end here by saying one thing in the defense of health economists and economists in general. The way the field of health economics has evolved has given a tremendous volume of extremely useful literature, tools, alternative approaches to thinking about market and non-market organizations. It is just that maybe there has to be a coming together of different disciplines what economists can do, obviously, maybe sociologists cannot do, or only public health specialists cannot do. So the kind of tools that has developed over the years for health sector analysis are completely indispensable, but they can be modified and made better by interaction with other people who have other insights into what makes the health sector work or fail. Thank you.
Thank you, ma'am, for that amazing, enlightening talk, ma'am. And it's always very difficult to actually say anything after any of your talks. But ma'am, just a request that we had just skimmed the surface of political economy of health a little bit in NHSRC, and we would request you some over the coming 1 or 2 weeks to discuss it, take it further, and how we can do some more analysis, which becomes more meaningful and which people should be able to use and look forward to. Thank you, ma'am. There's a session on questions and answers that will be moderated by Dr. Ritupriya, ma'am, subsequently. Before that, ma'am, I will be introducing to you all Dr. Shayan Das, who will talk a little bit about HPSR framework, on which the JNU Center of CSMCH and NHSRC work together. So over to you, Dr. Shayan Das, please.
Dr. Das, you're on mute.
Sorry, I said thank you, Dr. Kotwal, for the introduction, and good evening to everyone from India. So are the slides visible?
Yes, it's visible.
Yes.
Okay. So I'll be presenting on the Dialogic Health Systems Research Framework, which was developed as part of a collaborative project called a Review of Health Systems Research for Strengthening Future Knowledge Management, Planning and Policy in India, Mapping State of the Art from Global to Local. This was jointly undertaken by the Center of Social Medicine and Community Health of JNU and the Knowledge Management Division of National Health Systems Resource Center. Now, just to give you a brief overview of the project and what exactly it entailed. So the starting point of the project was that there are continuing and emerging challenges facing health systems today, and particularly post-COVID, we can all see the need for more health systems research, but there's also a demand for better evidence-based health policy, among other things. However, once we searched, we didn't really find a lot of literature on systemic assessment of nature and content of health systems research, particularly from India at all. So therefore, the study intended to map the broad approaches and streams of health systems research, both conceptually and methodologically, through a review of the field post-2000s. But in order to do so, we needed to first develop an analytical framework which would facilitate a comprehensive review and would contribute to strengthening the field of the research and knowledge management, which is the health systems research framework. And how we actually develop that is through different phases, actually. So it started with a systematic review of health systems frameworks in global literature from 2000s. And followed by that, the framework was applied to selected health systems research studies from India, representing the history and diversity of the field in the country. And finally, a national consultation was held in JNU in 2023 October, and to receive feedback and inputs from health systems researchers from across the country. And based on those inputs and feedback, the health systems research framework was finalized, and we called it the Dialogic Health Systems Research Framework. I'll come to it why we are calling it dialogic later. Now, broadly, the outcomes that we found from the research project itself. First, the systematic review, it revealed that most of the conceptual studies in health systems research originated from authors located in high and upper middle income countries. And there was very little research specific to lower middle and low income countries, including India, specifically conceptualizing conceptual research. It underscored the need for generating a health systems research framework which would be suited to the context. And therefore, the major outcome of the research process was the development of the health systems research framework. And through the process itself, we also found a spectrum of research paradigms which are being used in health systems research, from positivist to holist. And we also saw that based on the choice of the paradigm, the same research questions were being addressed differently. Now, here I'll be presenting very briefly about the spectrum of the research paradigms and the tool itself. Now, if we look at the research paradigm, we find broadly these 4 categories which are being used in health systems research as we found through our systematic review. So which are positivist, conventional public health or pragmatist, critical realist, and critical holist. And if we move from left to right, we see an increasing consideration of diverse sources and forms of knowledge, like lay knowledge, medical pluralism, and so on. An increasing consideration of complexity of the system as well, which is about the interrelationships, the adaptability of the system, the unintended consequences, and so on. Next slide, please. Now, if we look at the potential use of the framework, that would give us a better idea about what the framework is actually intended for. So the framework, as we have developed through the research, it can serve as a reference guide for the researchers before commencing on health systems research, and in the process of designing their study to assess conceptual, methodological, and normative choices. It can also serve as a guide for reviewers to assess the robustness of theoretical and methodological conceptualization of HSR relative to its objective and purpose. This also helps in selection of appropriate research proposals by institutions for undertaking research or for granting funds. And thirdly, it can give a comprehensive review of different policy choices, which can potentially help revise the program formulation and so on. So therefore, there's an use for midterm reviews of major programs as well as end evaluations. Now, moving on to the health systems research framework. It has broadly 2 components. The first is the description of the research, and second is an assessment of research coherence. The graphic that we see, Liz, the previous slide, please. Yeah. The graphic that we see, it broadly represents the health systems research framework and how the different analytical components of it in terms of conceptualization, methodological analysis, and so on, come together in synthesis of research coherence is what is presented through the graphic. And as we can see, values and principles, research paradigms form the outermost in all-encompassing influences on the method of the research itself, which includes conceptualization, methodology, findings, recommendations, and so on. And research coherence assesses how each of these components fit with each other, how good they fit with each other in terms of whether the research objectives logically follow into the research conceptualizations, and similarly the methodologies follows from them or not. Now looking at the components in a bit more detail. First is the description of the research, which has the general summary information about the study in terms of the publication, author, institutions, funding, type of institution, type of research, objective, methodology, level of analysis, area of analysis, and so on. And then the second component, which is the assessment of research coherence, which is what I was just explaining in terms of the graphic. And now to come to the assessment of the research coherence, there are 3 background tools. Liz, if you go to the next slide. So the assessment of the research coherence is done through 3 steps using 3 background tools. The first is analysis of values and principles for the health system. The second is analysis of health systems conceptualization. And the third is analysis of methodological approaches. So the first graphic represents the values and principles, which we have broadly divided into health system goals and health system functioning. Under health systems goals, sustainability, equity, people-centeredness, context appropriateness are the major ones. And then we have a whole lot under health system functioning. So this is as we have found from the studies and from our own analysis as well. But for the researcher undertaking the study, if they think there are certain other values which are important for the particular research or its objective, that could be included in it as well. So therefore, the framework is flexible in that way. The second is the health systems conceptualization, which the graphic shows, like it's what we already are familiar with somewhat in terms of the health system, its structures and processes, the boundary of the health system. What we have included is the dynamic elements of health systems and its context, which are influencing the functioning of the health system and the particular aspect which is being studied. And in different combinations, there could be certain dynamic elements working, or there could be 1 or 2 in different combinations. One important thing that we have added to the health system conceptualization is the health system vantage point. So I'll come to that later. And the third is the methodological approaches which were used in developing the research. So these 3 components together help us analyze the health system's research coherence. Now, coming to a bit more detail into the tool itself. So the next slide. So the first is the tool for analyzing values and principles. And as we can see on the left-hand side, we have listed the values and principles that we have seen in health systems research from our review. And the next column would be for the reviewer to actually list what values they consider to be important for the study under review, and whether that value is present or absent in the study under review. And if it is present, in what way it has been incorporated. Then the next tool, which is about the health system conceptualization. It talks about boundary, the subsystems of formal health system, health service system, the informal health services. Important to note here is that we have included informal social arrangements, community practices for health, and so on under the dynamic elements of a health system and its context here. So this is coming from, as we said, like there's very little situated conceptual research on health systems from the low economic countries. And so therefore, informal social arrangements and community practices is something which is significantly present, as studies have shown, in India and many other countries, so to say. But these are not as much included within the health system conceptualization. If you look at the prominent ones, starting from the WHO to World Bank's control framework and so on. And informal social arrangements and community practices is something that we define as all informal societal arrangements for maximizing health and minimizing ill health, shaped by agencies of different actors, their interactions and emergent behaviors. This includes informal care, people's health preserving and improving practices, social support in ill health or vulnerabilities. Next slide. Then coming to the health system vantage point, which is another addition to the health systems framework. Now, health systems vantage point is something that we define as the analysis of perspective underlying methods of health systems research, planning, and policy making. Now, it is of two kinds: bottom-up vantage point or a social vantage point, and a top-down one or an institutional, top-down or institutional vantage point. Now, bottom-up vantage point is something which begins at the grassroots, at the community level, with the people who are meant to be the primary beneficiary of the health system, with all the components that prevail in their perception and practice. This is in reference to the progressive levels of the health system. So it starts from the community and then goes across the levels of the different health systems as it is important or relevant to their particular context. So this kind of a vantage point grants people rationality and agency and attempts to understand how they play out in those contexts. Whereas a top-down vantage point or an institutional vantage point, it starts at the top, beginning at the institutional level, with the planners and policymakers and what shapes their decisions, followed by dissemination of decisions and implementation down the rest of the levels up to the community. This therefore gives primacy to formal institutions and activities and their functional attributes. And a combination of the two is what we would hope the research aim for. So this is basically about the health system vantage point. And then finally, the third step or the third tool, which is for analyzing methodological approaches. The next slide. Yeah. So it has two components: the analytical approaches, which we broadly see in health systems research, like epidemiological approach, health system historical analysis, various kinds of social science approaches. And similarly, the columns are like similar across the three tools in terms of what the reviewer feels relevant for the researcher for the particular study, and what is present or absent, and if it is present, in what ways it has been incorporated into the research. Historical analysis, social science approaches, management science approaches, ecosystem approaches, and so on. So these are the analytical approaches. Then we have the operational approaches, natures of disciplinary interaction, whether it's interdisciplinary, multidisciplinary, transdisciplinary. And finally, the research paradigms. What we had shown in the spectrum of the research paradigms, one thing I missed there, is that positivist, critical realist, critical holist, these are well known within the field, and critical realist, Dr. Markle has excellently explained just before. But what we found in our the project, the research itself, is that there's a spectrum in terms of the realist as a block itself. We can see two tendencies within the realist framework in terms of its application. So I'm talking about the paradigms, how it's being used. So if we look at the realist block, there are two tendencies, one being realist closer to positivist and the other being realist closer to holist. Now, it depends on how broadly or narrowly the context or the various mechanisms are defined and so on. Another one, which is not as well known, is the conventional public health or the pragmatist approach. Now, this is something that we found during our review. We define this particular paradigm as something that relies on framing the health problem from an epidemiological and problem-solving approach, designing levels of prevention to deal with it from structural to the individual level. Now, linkages with societal processes and context are minimally defined, with little social theory being employed. This uses primarily quantitative methods combined with a priori social and organizational knowledge. Epistemologically, this paradigm follows a pragmatist stance that is focused on practical application of knowledge to real-world settings. Now, so this tool comes with also a glossary, and as well as the glossary includes definition of each of these different terms and their references. And also we have a list of the paradigms and their tendencies and attributes as we find from the literature. And it's upon the reviewer to go through them and decide what actually works for them. And it's flexible in the sense that the reviewer themselves or the researcher who is using this framework can define their own way the different components which are included in the framework. But the idea is to make it explicit and make it available to everyone so that they know like where the other person is coming from. So this brings us to the idea of the dialogic in the dialogic health systems research framework. So what Dr. Gupta mentioned at the end of her like very interesting talk about health economics is that we need more interactions between the different research methods and the different disciplines which are dabbling in public health and so on. So the idea of the dialogic health system research actually comes from that. Is that the greatest strength of health systems research is perhaps the diversity that it has in terms of the various ways it has been tried. Researchers have tried to understand and address the issues within health systems research. And we see a number of frameworks developing over the time, starting from WHO's building blocks to World Bank's control law framework, to systems dynamics framework, to HPSR software and hardware, and so on. But the problem seems to have been that there has not been a common language or a common research framework which would allow people to understand, describe, and explain the system structure and functioning for ourselves as researchers, and as well as for communicating with the peers. And the common language and framework should be such that it is able to make sense of the formulation of HSR, allowing for the diverse paradigms that appropriate place in HSR and making them talk to each other rather than against each other. Like how we have looked at the research paradigms, and as we have found from the research, they are not placed in any kind of hierarchy in terms of which provides better evidence and so on. It's that each paradigm has specific purposes and it provides specific understandings. And it's for the research based on its purpose and objective to decide which paradigm to use or not. But the research framework hopefully would allow to actually state explicitly what are the various conceptual, methodological, and normative choices which have gone into developing the research. So therefore, people coming from different paradigmatic positions or different kind of disciplines can actually talk to each other and create a dialogue towards betterment of the evidence that informs public health policy and planning and ultimately implementation. So this is broadly the dialogic health systems research framework, and I'll end here. And so it's probably a lot to take in a short period of time, but as soon as the papers come out and all, I think it would be much more widely accessible. Thank you.
Thank you, Dr. Das, for that brief about the framework. Over to you, Dr. Durpriya, ma'am. Dr. Durpriya, ma'am?
Be muted. I'm sorry. Yeah, I was muted.
Over to you.
Yeah, sorry. Yeah. Thanks, Dr. Kotwal, and really heartfelt thanks to both the speakers for their very enlightening way in which Professor Markle brought in complexity, sensitive approaches, and the whole trajectory and journey of that movement in realist approaches, and then explaining that so clearly. And to Indrani for, again, giving us the trajectories across, because those trajectories seem to be where we all are and need to be finding our places within that, and understanding those trajectories is so useful. It was also interesting to see how the questions were very similar for both, and yet there were different points of takeoff and different approaches completely. And therefore, we hope that our framework will really, in some way, help in bridging these diversities while keeping the diversities alive. But we'd really welcome feedback on this, and would welcome anyone who'd like to engage some more with the framework and its details. With that, I'd really move on to our discussion session initiated by the two discussants whom we've invited to lead the discussion. And I'd invite Dr. Colonel Arun Kumar Yadav, who has been a professor at the Department of Community Medicine, AFMC Pune, is a MD in PSM and with a PhD in epidemiology, and has done an advanced course in GIS as well. He's a fellow of several professional associations, has trained more than 1,500 undergraduate and postgraduate scholars in research methodology with workshops, and published more than 200 peer-reviewed articles. In 2023, he gave the J.E. Park Memorial Oration. So over to you, Dr. Arun Kumar Yadav, for your initiating the discussion. What are the highlights you see, and what further issues would you like to bring in?
Thank you so much, ma'am. Am I audible?
Yes, you are. We can see you and hear you.
Yeah. First of all, it's a privilege and honor to be invited for this 50th webinar series and for this fifth in this series. And this wonderful work done by Center for Social Medicine and Community Health since 1971, wherein it was initially formed. And I am really excited to be amongst the panelists who are like experts in their field, doyens in their field, and have been my teachers also. And my special regards to General Kotwal sir, who is also co-chairing the session. So I want to bring few points of each remarks or the presentation which we have listened to. So this initially the work itself, the HPSR or HSR, these terminologies have been changing over past 4 decades, and it has initially took from the policies in social sciences and managerial research as such, and thereafter there was this health service research, which was very that term which was used by high income countries, and there is this health system research and policy studies. So when we talk about this HPSR or a health system research or policy studies, it actually means for policy as well as on policy. So the example which was given by General Kotwal sir, that ASHA evaluation and then the programs were changed, they were probably examples of how you can work on policies, on existing policies, and kind of modify them or improve upon them. Then there was this talk by very interesting and very captivating talk by Dr. Bruno Marshall, wherein he talked about the complexity of the nature and how within the real paradigm, this complex plays with different actors as well as the mechanism which is there. And then we had a talk on econometric tools by Dr. Professor Indrani Gupta, and then this health system framework tool, which I am very happy, which is being prepared with collaboration with Center for Social Medicine and Community Health as well as NHSRC was presented. However, I want to bring in one point from an Indian perspective, that where we are and why are we lacking in health system research. So if you see that most of the research of health system research has been done by researchers of high income countries. In your research, in your systematic review also, ma'am, wherein you have found 60 articles, 49 of them have been written by main lead authors were from high income countries. That means more than 85% of the studies in India itself have been done by foreigners. So while it has been done by foreigners, over a period of time, what we have seen on an international stage is that these studies, which have done by only a special class of people, and they, when they do study, of course, they study the they they study the health system of that particular country. However, they might lack, what they might lack is the perspective of the natives of that particular country. So this perspective of particular country can only come with when more and more researchers who are trained in Indian context can come and do these health system research. So in this way, I can see that both uh, CHMCH and MHSRC can take lead and project more research in health system research by Indian people. Sometimes I feel that the terms like diversity and inclusiveness were coined just to make, I mean, this is my this thing, when you read more and more, you come to know that maybe the term like diversity and inclusiveness were coined so that the researchers which are done by the people outside on the various low income countries can become more acceptable. Also, when we talk about various paradigms, there is like if a researchers, why why these studies like health system research studies are difficult to do. There are multiple reasons for this. One of the reasons which I talk about, which I would like to highlight, is the study design. That the normal study design, which an epidemiologist is being taught, may not fit for doing health system research. Most of the health system research required adaptive designs and iterative designs. That means that while doing research, you can refine your own methodology, which is, I mean, not understandable by a pure epidemiologist or who is doing pure quantitative sciences. So we have to build in India itself, more methodologists who could accommodate those adaptive designs, which we can obviously then put forward for making our health system research design more robust. The other thing which I find that we require more practice is in system thinking as a whole, which I find that in most of the talks we don't talk about system thinking. However, system thinking as a tool has been developed and is like very much in process or in generating evidence. I'm very happy to see how this health system dialogic health system research framework has come about, and I'm really proud of you, ma'am, that you have led that work. However, there are 2 points about that work. That work uh, now that most of the work, most of the that paperwork or most of the work which required a lot of inputs have been done. Now is the time to test it. What would require is if we can design some study based on this health system research framework as such, and see that whether those studies give more those studies generate more evidence in Indian context than any other studies. There is another word of caution when we see paradigms. So these paradigms are not compartmentalized. They should be taken as uh, like rainbow. That there is a seamless kind of movement from one paradigm to another, and we should not be reductionist to only one paradigm while doing our studies. So with this, ma'am, I uh, put up my few points which I have observed over this thing. If there are anything or any questions, you can take it further. Thank you so much, and it's a pleasure and honor to be here once again with the audience in the field. Thank you so much.
Thank you, Dr. Yadav. Thank you for your thoughts on that. I would now invite Professor Ramila Bisht as the second discussant. Dr. Ramila Bisht is a professor at the Center of Social Medicine and Community Health. JNU is a colleague in my center. Her research interests comprise issues related to health policy and reforms in India, comparative health systems and policies, urbanization, environment and health inequalities, and the gendered, social, and cultural determinants of women's health. She was awarded the British Society of Population Studies LDC Visitor Award in 2010. She was an embedded fellow in 2010 in the ASRC Rising Powers Network Award entitled India's Challenge in a Globalizing Healthcare Economy, Social Science Directions. Her publications include those co-authored with others on sourcing surrogates, actors, agencies, and networks, and environmental health in Garhwal, Himalaya, a study of Pauri Garhwal. Over to you, Ramila, for your thoughts.
Thank you, ma'am. Thank you so much for inviting me to discuss these three excellent presentations. And I have to thank Professor Bruno Markshall and Professor Indrani Gupta and Dr. Shayan Das for them. My response, I'm trying to organize them under 4 points. In the first point, I would like to look at the evolution and the paradigms in this field. Secondly, I would want to look at the definitional issues within that. Third, I want to look at this dialogic framework that has been developed. And lastly, my concerns about training, who should train and who should do this research. So I'm just trying to broadly put my thoughts under these 4 heads. Now, Professor Markshall already mentioned very briefly about this history of health systems research. And this history is very important. The trajectories, as Dr. Ritupriya called them, is very, very important because it reveals that these shifts took place over time. And we had health services research and we had health systems research. And these both were being done in high-income countries as health services research, while in low and middle-income countries, they were called health systems research. And slowly they transformed and moved and became health policy and systems research. Now, this evolution from HSR to HPSR was taking place parallelly in response to a lot of ideas that were evolving at that time, from primary healthcare to health financing to needs about the health sector reforms to health systems performance and strengthening of health systems. And it was at that time felt that we need to integrate the policy aspects which underlie this health system and its functioning. And international organizations, particularly the WHO, in collaboration with the Alliance for Health Systems Research, played a very, very key or central role in laying out this new research paradigm and enabling this transition from simple HSR to HPSR to take place. And new dimensions were added also because we had, ideas of, say, social determinants of health, health equities were also getting traction internationally. And then the MDGs and the SDGs gave further momentum and push to strengthening and disseminating this approach. So 1999, roughly, I think, when this was set up. And it took about 10 years for the leaders who were promoting this kind of an approach to start talking about incorporating the social science paradigms in it. And Professor Markshall had already shown us in one of the slides some of the important papers. They came out as a series of papers where they looked at the content, nature, scope of the HPSR, and they brought in ideas of deep complexity, power, ideology, social values, etc. within it. Now, what is very important for us to remember is that what was the driving force? What was the main factor which was driving this interest and expanding this conceptual framework? This was the recognition of need for strong health systems. And while health systems framework remain contested, there was a realization that the health systems are not just complex, but they're at core social institutions. And therefore, the significance of social sciences came in to try to unravel this complexity, and therefore the incorporation of all these paradigms was done. Now, these new paradigms that were brought in, nobody would doubt its relevance. They hold a great, yet largely untapped potential for health systems research, but they carry within them a lot of challenge. How do we convert these concepts and principles from abstracts to actual practice? And how do we continue to learn and to share them? Now, this is absolutely a big challenge. And while nobody would dispute the relevance of these paradigms, and the idea of expanding the paradigms to theoretically grounded, methodologically pluralistic, flexible, adaptive designs, but it's another thing to have capacities to do that. And I don't know globally, but in India, I think we fell very short. Professor Marshall is heading a unit on complexity in health. I don't think in India we have any such unit in this country. Further, these paradigms also talked about, inter, multi, and transdisciplinary approaches. However, if it's my hunch, I feel the discipline of economics from among the social sciences still continues to provide the dominant framework for health policy and systems research, and the relationship between this and other disciplinary approaches has not yet been well articulated. Of course, I'm aware of SHAPES, which is the thematic working group under the health systems global. And this is just a hunch. I think we need to study it and to understand that. Now, there is one thing about breaking these boundaries or crossing these boundaries between disciplines, but what about boundaries between science and society? They also need to be transformed. And that's also something that I think when we're thinking of paradigms, we need to look into. Now, my second point is the title of this webinar. I found that very, very interesting. We constantly talk of health policy and systems research, but my team here has named it Health Systems Research and Policy Studies. Now, I'm sure this is not just a matter of semantics, and there is some thought that's gone into it. I do remember that there is CHEPSA, the Consortium for Health Policy and Systems Analysis in Africa. They developed their approach and they called it Health Policy and Systems Research and Analysis. And the acronym that they use for it is HPSR plus A. I don't know enough about that, but I do think there is some kind of thinking that went into that. And there is some shift from this global, much accepted HPSR. Now, my question is then, are these kinds of conceptions like this African HPSR plus and our HSR and policy studies an effort to decolonize knowledge? Are they pointing to false universalism of global HPSR? Perhaps it calls our attention to coloniality in the HPSR frameworks. Given that the continued basis of all this knowledge generation and knowledge production, ownership that is taking place still continues to lie largely within the high-income countries. Now, having said that, I think Dr. Ritupriya and team need to actually think about this and also, sort of elaborate this conception a bit more. Maybe from Shayan's brief presentation, what I gathered was that the organizers want to demarcate policy studies from health systems research, basically as an attempt to treat policy studies as a complementary layer to health systems research against this integrating of policy analysis within the framework of HSR as was being done in health policy and systems research. However, I think we need to hear more from them. I'm not very clear, but we need to hear more from them. But what I wanted them to think about and respond to is, then in doing so, are we not then privileging one discipline, in this case, public policy or social policy, over other disciplines? Now, if that is so, then this seems to me to undermine the very purpose of this whole exercise or of developing this framework. And also, we must remember that the policy studies also have been rooted in the Western context. And much of the early work in policy studies comes from that context. And it is in very recent times that you've seen some kind of work emerging, which is trying to look at our context, which is like trying to understand or differentiate public sector values and conditions that are in the developing world. So this kind of limitations of policy studies, I think, needs to be taken on board. The framework per se, coming to my third point, the framework per se was very, very interesting. And while it's not entirely different from the HPSR framework, what I found very interesting and potentially novel was this inclusion of informal healthcare. As it acknowledges not only this very overlooked role that these informal practices play within our health systems and within our context, that makes it, I think, very, very important. But it might be valuable to the authors of this framework to explore how these informal practices can be better and integrated into the health systems framework, and how this expanded approach can enhance our understanding and management of the health systems. But I must also share my discomfort with frameworks in general. Much of the HPSR space relies heavily on frameworks with boxes and arrows. And while I understand that these frameworks are there to simplify things, to help us to simplify our understanding, to lay out the scope of the inquiry, but I do feel that they tend to distract us from the lives involved and the political agendas which are served by these abstract conceptualizations. So they have their place, undoubtedly, as long as we understand that the processes and experiences that operate within this human society will be explored in its complexity and don't remain simple in terms of the boxes. Lastly, my question of who will train and who should research. Now, I remember when I joined TISS in 1994, I was a young faculty at that time. HSR training was was getting started in the country. I was sent to NIHFW to become a trainer and then come back. And for years, we did training of the whole Western region on health systems research. And then suddenly this stopped. Now, when HPSR training started, at least in my country, when it started, I feel the whole responsibility of this training was given to civil society research institutions and to private institutions outside the domain of the university. Now, I have nothing against engaging these institutions for capacity building, and I do see their relevance. But it's the leaving out of the universities from this endeavor that concerns me, because universities are very, very crucial for building this field. Because not only do they produce knowledge, they foster the next generation of policymakers, health professionals, as well as researchers. So I think it's very important that we think about how do we bring back this into the domain of the universities. The researchers who want to engage in these kinds of paradigms have a challenge in front of them. They need to educate themselves in these approaches, and then they will be in a position to train others. So we need to build this into our public health curriculum. We need to have this instituted. We need to have this instituted in educational spaces, because to me, a lot of these complicated paradigms I call them complicated because I do find them, even being a social scientist, extremely complex. They're not amenable to a week-long, 10-day workshop or a manual that's made on them. I think it requires us uh, to engage with this, to learn as a team, to work with people across different departments outside of the institution, to come together to make, using these paradigms more possible for us. I think I'll stop there. Thank you.
Thank you, Pramila. Thank you for those very, very rich thoughts. And I'm sure they may have also raised some further questions, but we are constrained for time. I'm sure we're eating into some people's dinners. So I will just pick up some questions that are there in the chat, and also invite anyone who has burning questions to either put it in the chat or raise their hand, and we can then ask them to directly ask the question very, very briefly. In the chat, there are several comments, some very congratulatory and positive about the presentations and about the framework. Also, one just pointing out to the fact that use of the word native is pejorative, and instead of that, local residents is a better term to use. But basically, the questions that I see is to Indrani asking about how does the exercise of estimating health costs factor in the vulnerable groups and their economics? How well is it able to capture the effects of the economic in their frame of economics? Indrani, would you take that?
Yeah, thanks. The question is very broad. I mean, first of all, it all depends on what the exercise is about, what research questions it's asking. If the costing, I mean, I'm assuming by health cost, you're actually talking about a particular intervention. I'm not very sure. But if the intervention is targeted at the migrant workers or poor women, I mean, generally the standard practice would be obviously then cost it accordingly and look at all kinds of medical, non-medical, other kind of costs. But there is no general costing that takes into account vulnerable groups. I mean, costing is very research question specific and context specific. So I don't know whether I understood your question properly, Ms. Mohanty. But generally, if you're costing an intervention and targeting those that intervention at migrant and poor women, for instance, then of course you would try your best to take into account the health costs. But if you're doing something different, then there are many more groups that are relevant at that point. I mean, it's a public health intervention that would impact on not only migrant workers, poor women, but all kinds of maybe school children and the elderly, then yes, that's exactly the point I was trying to make, that public health interventions are generally not easy either to quantify or to cost, and we need much better tools to do so, because you are addressing population issues rather than a sample issue. So your concern is very genuine, and I think that a very good costing exercise would try and do that, but there aren't many of those around, that's for sure.
Thanks, Indrani. I think that was explicit enough, and telling us how when we do the larger public health systems and so on, we find some of these gaps. There's a question that Sukanya again has asked, saying how does the realist theories and research look at unintended consequences of interventions, for instance, of reemergence of diseases which have been attempted through particular kind of program designs, whether it's TB or polio, diphtheria, and so on. And with the unpredictability of human behavior, how do you look at unintended consequences?
Yeah, no, that's a good question, and I think it's one that is being addressed by all of the theory-based approaches. But within realist, we are not only looking at the expected and the planned and the intended outcomes, but also the unexpected. And so the difficulty is rather how to pick up these unintended effects. And if you stick within more traditional prospective data collection for narrow kind of evaluations, you may miss important information. So it is a task of realists to pick up any outcome, including the unintended. So it's part of the game, in fact, of the unexpected emergent outcomes that may happen, which you need to pick up. And so it's part of the task, if you want, but you need specifically to take that into account and not to be too narrow in your data collection. Yeah.
Thanks. I don't see too many other questions. If anybody has questions, would you please come up with them?
So one hand was raised earlier, Aruna's hand.
But I don't see her here now. So maybe she's just became too long and she's left. Yeah, I think we're... So if there are no questions, we can start doing a close-up of this webinar. And I would request Professor Kotwal, if you would have any closing remarks to make.
Thank you, ma'am. No, I think we have discussed quite a lot after those enlightening talks, and we noted the way forward from the two talks, plus also Professor Arun and Professor Ramila's concerns raised by them. And I think we need to, sit down again and look at our framework and also how further to start utilizing it. And also, again, discuss with few more experts to see how we can refine it further as we start using it. I think I'll stop here because we are, I think, standing between people's dinner and all right now. So I'll request Dr. Neha Dumka to pose a formal vote of thanks.
Thank you, sir. Thank you, ma'am. Good evening, everyone. So I would like to take this opportunity to thank each one of you for your active participation and such a great discussion. So firstly, I would like to thank all the participants for joining today for this enriching discussions and their active participation, including some really important questions which were put forward during the discussions. And then I would like to thank our keynote speakers, Professor Bruno Marshall and Professor Indrani Gupta ma'am, for such an in-depth discussion on realistic evaluation as well as the perspective of economic evaluations. So your insights on what approaches on complexities and the importance of in research in perspective of the realistic evaluation as well as the economic evaluation was really important and very enlightening for all of us. I would also like to thank Dr. Sayan Das for presenting such a crisp yet comprehensively the HSR framework. It was really a great experience working collaboratively together for developing that framework. Hope it turns out to be the way we had planned. And I would also like to take this opportunity to thank our panelists, Colonel Arun Yadav sir and Professor Ramila Bish ma'am. While further dwelling into the discussions, these panelists also highlighted the key takeaways and discussion points, which actually made the discussions more useful for all of us. Thank you, sir, and thank you, ma'am, for that. And I would also like to now thank our chairpersons who were not only anchoring this process, but also had guided us organizing this webinar in collaborative manner. Thank you, Professor Ritu ma'am and Major General Professor Atul Kotwal sir for all the guidance, support, and showing us the way in organizing this webinar. Now, I have some special people to also thank for organizing this event. I would like to thank who all they assisted us for organizing this webinar. Dr. Shivangi Sarkar for not only developing the poster and providing the support, and Manmohan Singh ji, who was also helping us in sending the announcements and the invites. Dr. Indranil, who also provided us the Zoom platform, and CMSCH Alumni Association, who worked for developing this thing on the YouTube channel. I would also like to thank our Knowledge Management Division at NHSRC for overall support, and everyone at NHSRC and CMSCH for helping us in organizing this webinar in a collaborative way. Thank you, everyone. Thank you so much.
Thank you, Neha. I'd just like to inform everyone that the series we hope is still continuing. There's work in progress on at least 2 more webinars, one on digital health and another on environment and health. But the information of that we'll do once they are finalized. So thank you, everyone, and good night.
Thank you, everyone. Good night. Thank you.
Good night.
Thank you. Good night.
The recording has stopped.